thanks for everyone for joining. So I know all these audience, so that's great. We're gonna go ahead and start. This is Get MASLD MASH Community Network sponsored by Madrigal. Thank you very much for joining me today. My name is Valerie, Shin nurse practitioner. I work at Flagler Liver Institute at UCLA, Los Angeles, California. This is part of Get MASLD MASH Community Network series. This community network is very unique because we have experienced group of APPs from across the country, and each APP leads Zoom presentation to share and discuss all aspects of steatosis. These sessions offer insightful discussions, best practice sharings, and then interactive learning. Today, we'll cover the basics of MASLD. You are already registered for this meeting, so you don't have to do this. But if you'd like to share with anyone, please quickly share this with anyone who would like to join. It's never too late. You can send them this QR code so they can join as well. Please also visit this QR code. I highly recommend you to check out this website. This is to view Madrigal's MASH disease state education and Madrigal's drug Resdifra promotional program. Before we get into basics of MASLD, we need to know what steatotic liver disease is. The old name for this condition is fatty liver. So many providers are familiar with the term, but patients often don't like hearing that they have fatty liver. We used to put fatty liver patients into two different boxes, alcohol-related or non-alcohol-related. And because of this, a lot of people assume having a fatty liver means heavy alcohol use. It is actually very common. I tell my patient, you have evidence of fatty liver, and their response is usually like, I don't drink alcohol. See what I mean? So it carries a very negative connotation. So about 2 years ago, experts came together and reclassified the term fatty liver under a new umbrella term, steatotic liver disease or SLD. This new name brings together several different causes. Whenever I say steatosis, so that means fatty liver. So let's go over them. If a patient has steatosis detected on imaging or biopsy and also has underlying cardiometabolic risk factors, we now refer it to as MASLD, metabolic dysfunction associated steatotic liver disease. Or when steatosis progresses and become inflamed, it is then called MASH, where SH stands for steatohepatitis. Hepatitis means inflammation of the liver. Both MASLD and MASH represent the majority of cases within the SLD. If a patient has a cardiometabolic risk factors and a history of alcohol use, we combine the term and use the name MASLD, metabolic dysfunction and alcohol-associated liver disease. We classify patients as having either MASLD or just ALD, depending on the amount of alcohol they consume. So one standard drink contains about 14 grams of alcohol. The orange highlight shows the reference range, whether the patient is towards the MASLD or ALD predominant, based on the daily or weekly alcohol consumption. There is no safe level of alcohol use. Based on ASLD, in general, women without the liver disease should consume no more than 1 standard drinks per day, and men no more than 2 standard drinks per day. So anything more is considered significant amount of alcohol use. Patients with any underlying liver disease, they should not be drinking any alcohol. And please remember, not all steatotic liver disease is related to metabolic or alcohol. Some patients don't have high blood pressure, diabetes, dyslipidemia, or obesity, or does not drink alcohol at all, but still have steatosis, which might be caused by other things like drug-induced liver injury, Wilson, environmental toxins, HIV, or sometimes there's just no known cause we call cryptogenic. MASLD definition. This is similar to the previous slide. Basically, this is the flow chart you can follow easily if you're not sure where to categorize patient with steatosis. So let's recap. A patient came into the clinic with an incidental finding of steatosis. The next thing is to see if patient has metabolic risk factors or not. If yes, the patient fall into either MASLD, MASH, or MASLD. If not, they fall into other criteria like we discussed earlier, like ALD, DILI, Wilson, HIV, and so on. There's a slight different cardiometabolic criteria between adult and pediatric. So we'll focus on the adult criteria only because that's my population. It is on the next page. This slide emphasizes the importance of recognizing metabolic risk factors in steatotic patients. Number one, BMI over 25, but please do remember for Asian patients, body mass index over 23 is already considered as overweight, or waist circumference over 37 inches in men and 31.5 inches in women. Number two, fasting glucose over 100, or A1C over 5.7, or have type 2 diabetes. Number three, blood pressure over 130 over 80, or already on treatment for high blood pressure. Number four is triglyceride over 150, or already on lipid controlling agent. Number five, HDL. I actually call this high five cholesterol. It's supposed to be high, but lower in 40 in men or lower than 50 in women. If a patient has at least one of these elements, patients meet criteria for having cardiometabolic risk factors. So MASLD is presence of steatosis in setting of cardiometabolic risk factor in the absence of significant alcohol use. So how is this name change affect my practice? We used to call non-alcoholic fatty liver patients as NAFL, and when we look at this population more closely, we found that 99% of these population actually overlap with the MASLD group. So what does this mean? This means almost all non-alcohol related fatty liver patients had metabolic disease, like the ones we mentioned, high blood pressure, diabetes, dyslipidemia, or elevated BMI. So any recommendations made for NAFL and NASH in the past, in the ASLD practice guidance, exact same thing can be applied to the patient with MASLD and MASH. Results from natural history and biomarker validation studies for NAFL and NASH studies, patients are totally applicable to the patient with MASLD and MASH. There are a lot of tongue twists here. So when you look at old literature, if it says NAFL, you can safely assume that means MASLD. So MASLD is new NAFL and MASH is new NASH. Okay, MASLD is a global health concern. The prevalence of MASLD in North America is about 25 to 37%, meaning at the lowest rate, 1 out of 4 Americans have steatosis. Some areas, there are 1 out of 3 people who have steatosis. That's a lot of fatty liver or steatosis. We have to use a new term. Some Middle Eastern and South Asian countries have even higher rates of MASLD. The highest rate is seen in Latin American countries, ranging from 30% to 59% of the population. That's close to every other person being diagnosed with MASLD. We believe that poor diet, like too many non-healthy but taste good food options, is one of the leading causes, along with the increasing rates of obesity and metabolic syndrome. Genetic predisposition, of course, plays a role. It is critically important to identify individuals with MASLD and MASH and intervene early. Steatotic liver disease suspected in primary care management. It is often the primary care providers who identify patients with steatosis incidentally. So it is very important for any providers who face the patient with metabolic risk factors to be aware of easy screening tool to risk stratify these patients. There's a very simple non-invasive test called FIT4 that can be used in primary care setting to evaluate patient to predict the risk of developing fibrosis. FIT4 is a clinical calculator, and we input age, platelet, AST, and ALT. If this number is lower than 1.3, in general, we can consider them not worrisome for fibrosis. If so, referring patients to hepatology clinic may not be necessary actually. FIT4 can be repeated every 1 to 2 years with primary if patient has diabetes or 2 or more metabolic risk factor, or every 2 to 3 years if patient has no diabetes and less than 2 metabolic risk factors. Regardless, patients should all be counseled on healthy lifestyle changes like eating healthy, routine exercise, and all that. When patients have FIFO score between 1.3 to 2.67, they fall into indeterminate range. Then we recommend primary providers to run more non-invasive tests to assess the risk of fibrosis. And most two common examples of non-invasive tests, we call it NIT, are VCTE, such as brand name FibroScan, or ELF, Enhanced Liver Fibrosis Blood Test. When the FibroScan or ELF score is higher than the cutoff, patients should be encouraged to see GI or hepatology. Send it to me. When patients' FIFO is way more elevated, more than 2.67, and liver enzymes are elevated persistently, they should be directly referred to CGI or hepatology or me because patients are at risk of MASH or cirrhosis. Okay. Once advanced fibrosis is suspected, either clinically or based on non-invasive testing, hepatology or GI providers should take the lead. In some cases, we order liver biopsies, especially when a patient continues to have elevated liver tests, but then imaging and serology do not match. But most of the time, we can diagnose steatosis liver disease without a liver biopsy. We don't like biopsy no more in steatotic group. After evaluate patient's fibrosis stage, the patients with F0 to 1 fibrosis are recommended reassess in 2 to 3 years, or sometimes we'll return patients back to primary for routine monitoring. For F2 to 3 fibrosis can be considered for a drug therapy, the new and only one drug for MASH, resmetirom, to decrease fibrosis and steatosis, and reassess every year for liver fibrosis. For F4 fibrosis, now it's more like cirrhosis management, especially when they have decompensation, and to see if patient needs a liver transplantation evaluation or also for liver cancer surveillance. Let's discuss the progression and natural history of MASLD. Among the US population, approximately 336 million, up to 80 million people are estimated to have MASLD. And of those, about 25% develop MASH. That is almost like 1 out of 4 Americans have MASLD, and among them, 1 out of 4 becomes to have progression of MASLD. In patients with MASH, liver fibrosis can develop over time. The average rate of fibrosis progression from one stage to the next is about 7 years in average. However, around 20% of patients are considered fast progressor, and they may develop liver cirrhosis from simple MASLD as fast as within 10 years. Because steatosis causes no symptoms, this is very scary. And one day, patient can show up decompensated without even knowing that they had MASH for the last 10 years. Among 20% of F3 fibrosis patients develop cirrhosis in 2 years. Importantly, MASH, regardless of fibrosis stage, carries a slight increased risk of developing hepatocellular carcinoma, HCC, or liver cancer. Patients with cirrhosis, that's roughly about 1 to 2 million people in the US, and the liver cancer patients face a significantly higher risk for liver failure. Liver-related mortality can affect about 30 to 40% of those individuals. And some are blessed to get liver transplantation. Here's another visualization of this disease progression. Starting from a healthy liver on the left, MASLD can develop in the presence of metabolic syndrome. Over time, this can lead to scarred liver fibrosis. If fibrosis progresses, it can result in cirrhosis, and then to liver cancer. There are studies that explain that genetic predisposition to steatosis plays a role. For example, PNPLA3 is a key genetic factor most strongly associated with liver fat accumulation, inflammation, fibrosis, and progression to MASH and HCC. It is common in Hispanic populations, partially explaining higher MASLD prevalence in Latin American countries. The key point of MASLD and MASH, based on AASLD guidance 2023, MASH plus F2 to 4 fibrosis is associated with higher risk for liver-related events and mortality. The rates of fibrosis progression and hepatic decompensation depend on baseline disease severity, genetic, and individual environmental and comorbid disease factors. Cardiovascular disease and non-hepatic malignancies are the most common cause of mortality in patients with MASLD without the advanced fibrosis. So that's, in other words, patients with MASLD who don't have advanced fibrosis usually don't die from the liver disease. Instead, like heart disease and cancers that's not liver origin are the most common cause of death. The death from liver disease is mostly in patients with the advanced fibrosis or cirrhosis. So this slide emphasizes the value of staging fibrosis early and treatment planning before too late. So let's apply this to a real patient scenario. This is JP, 55-year-old white male. He was referred for elevated liver tests. That's new. His AST, ALT is 50 and 45. Well, that's not super high, but that's not completely normal either. So mild transaminitis. Prior, his liver tests were normal. He has right upper quadrant discomfort. He has gained about 20 pounds over 5 years. JP has past medical history of obesity with BMI 35 and prediabetes with A1C 6.3 and hypertension. He has no known family history of liver disease. He drinks alcohol, but very little. That's per him. Works in IT, most likely has sedentary lifestyle. He takes lisinopril for his blood pressure. On physical exam, his waist circumference is more than 37 inches or 110 centimeter. He appears centrally obese. I'm sorry. This is very typical clinical presentation of MASLD. When we make a diagnosis of MASLD, we have to make sure that this is not medication-related steatosis or some other liver condition. For example, amiodarone, methotrexate, tamoxifen, 5-FU, corticosteroids, valproic acid procedure, and older antiretrovirals can contribute to steatosis. And Mr. JP does not look like taking none of these medications. He's only on lisinopril. And you also want to rule out other etiologies first before we state that you have MASLD. Be sure to rule out Hep C, copper iron overload, HIV, anorexia, celiac, post-Whipple, which I've been seeing a lot lately, and use of TPN, rare genetic disorders, and etc. For further evaluation of JP's abnormal liver test, I will send some following serologists to rule out any other chronic liver conditions before I state him that you have MASLD. So let's see if you and I are thinking the same. So the first and most, I'll send the viral hepatitis serologist and ferritin and iron saturation, celiac panel and anti-nuclear antibody, serum IgG, smooth muscle, alpha-1 antitrypsin. This is to rule out viral hepatitis, iron overload, celiac disease, autoimmune hepatitis, and alpha-1 antitrypsin deficiency. I tend to send anti-mitochondrial antibody only if patient's alkaline is elevated to evaluate whether a patient has PBC or not, primary biliary cholangitis, but I believe JP's alkaline was actually normal. Baseline CMP, CBC, and INR will help to see any signs of liver cirrhosis for especially albumin, platelet count, coagulopathy status, and in need of MEL score if someone has a cirrhosis. HIV antibody, TSH can be helpful too. What else? And I'll go ahead and order A1C and lipid panel for Mr. JP's metabolic disease screening. And I love PATH test. PATH test, we use it very often. It's been greatly helpful, especially because it will show the alcohol use behavior of last 30 days. Imaging plays a big role. A simple ultrasound abdomen can show the presence of steatosis. I personally prefer to use ultrasound abdomen complete to begin with to see the spleen size as well. But please remember, ultrasound abdomen only detects moderate to severe steatosis. It's the mild steatosis can be easily missed. Back to our patient. He had an ultrasound abdomen. He had an increase in hepatic echogenicity with areas of focal sparing. This is a typical ultrasound abdomen report with findings of steatosis. And if he because the spleen size is normal, I don't see any evidence of portal hypertension based on this imaging. Ultrasound is really good at telling you, yes, you have fatty liver or steatosis, or you don't have steatosis. But it's important that you have to remember ultrasound abdomen does not show the stage of fibrosis or presence of inflammation. So it's kind of impossible to see, oh, patient has MASH based on ultrasound now. We have a separate lecture series on different non-invasive testing tools for staging fibrosis, so check it out. Do we still use liver biopsy? In some cases, we do. We tend to stay away from any invasive procedures if possible, especially for fatty liver patients. But sometimes biopsy is needed because the finding on non-invasive testing results do not match, it's conflicting or indeterminate. Liver biopsy can provide information whether the patient has any fibrosis, amount of the fat, and if there's any other chronic liver conditions, such as autoimmune hepatitis, iron overload, and drug-induced liver injury, or anything like that. For JP, let's follow this flow chart. Patient had negative serology workup for chronic liver condition, right? And he is found to have steatosis on abdominal ultrasound. So he meets criteria for the first box. The next question is if he has a metabolic risk factor, and he does, right? He has increased BMI of 35, prediabetes, high blood pressure already on antihypertensive medication, and his waist circumference was large. Next, does he have any other obvious cause of steatosis? I would say no, because he drinks alcohol but very rarely. Therefore, he meets criteria for diagnosis of MASLD. So Mr. JP has just been diagnosed with steatotic liver disease, highly likely from MASLD. So after this, we still need to ask some more questions to answer. So we know he has MASLD, but does he have MASH? Does he have any fibrosis? If so, like what stage? So what are next steps to find these out? So if anyone has microphone allowed, you can talk. Let's see, where's my screen? I'm gonna give you 5 seconds if anybody wants to talk. Okay, I'm just gonna talk. I think we should proceed with non-invasive testing such as FibroScan. But JP's BMI is a bit high with large waist circumference, so I can consider doing something else like ELF score or MRI elastography. I mean, we can certainly try to do FibroScan first. It's cost effective actually, and we have it available right here. Liver biopsy can be considered if these results are like kind of not matching. After this NITs, if it suggests F0 to 1 fibrosis, of course, lifestyle changes, portion control, heart healthy diet, Mediterranean diet, high controlling metabolic risk factors, lose weight in healthy way, and will restage in 1 to 3 years. If JP has evidence of F2 to 3, the drug resmetirom can be considered, but of course it has to come with healthy lifestyle changes. With evidence of F3 to 4 fibrosis, no MASH medication is not indicated for advanced fibrosis, but continued tight control metabolic risk factors, eat healthy, and liver cancer screening should be added every 6 months as well. That's it. Again, if you'd like to learn more about MASLD and MASH, we have multiple other parts of lecture series, and please check out the schedule on GAP MASLD MASH Community Network. If you'd like to learn more about how to manage MASH with advanced fibrosis, I have another presentation coming up next week, same time, Tuesday, 5:30 Pacific time. Please register using this QR code. Otherwise, we're done. If you have any question, I'll take it.